My name is Amr Azim. I'm a reproductive endocrinologist at New York City IVF. I wanted to talk today about how do you go about picking a fertility treatment. So you are trying to get pregnant and it has been delayed for 6 months or a year, and what are the things to consider in terms of your choice of a treatment. So the first thing to consider is how long have you been trying and how old are you? Both have been shown for a very long time to be important factors related to the chance of spontaneous pregnancy. How long have you been trying is measured by how long have you been having intercourse with no birth control pills or condoms, irrespective of your intention. And how old are you? We know that there is a strong relationship between age and both the number of eggs remaining in the ovary and the quality of these eggs. And this is also an important factor to consider. Not that this will be an all or none issue, but it will prompt you to interfere or be more proactive as the time goes by if you're older than if you are younger. That if you're younger, you can try a little bit longer on your own. Then you go to visit your reproductive endocrinologist, and he should systematically go through the major tenets of fertility. Your ovaries, the partner sperm analysis and sperm function, and the patency of your fallopian tubes. These are important information to gather. You want to know if your fallopian tubes are open or not. This is done by using a simple test called Hysterosalpingogram. You want to know if your partner has adequate sperm in terms of their count, movement, and shape, capable of fertilizing your eggs. You also, most importantly, want to know in details your ovarian reserve. Semi-quantitatively, how many eggs remain in the ovary, and also reflect on the quality of these eggs. And that's usually can be determined quickly using a vaginal ultrasound or using a blood test for anti-Mullerian hormone or FSH on the 3rd day of the cycle. There are also other tests related to the safety of getting pregnant, related to genetic screening and infectious disease screening. Once you get the information, you and your reproductive endocrinologist then becomes in a position to actually intelligently talk about your fertility. Many women at this point that I meet would say, I'm healthy, so everything is fine. Well, fertility is not about being healthy. Unhealthy women do get pregnant on their own too. It is about obtaining specific information related to specific function, namely the fallopian tube, the sperm, and the ovary. In addition, you might have certain requests that also should be taken in consideration in crafting a plan. And for example, you have no tolerance to twins or other higher order multiple pregnancy, as generally women should be. And that may entail modifying the plan in a certain way. Once you have gathered all the information, now you will decide on a plan with you and between you and your reproductive endocrinologist. And when you're comfortable with the plan, then you proceed. But before you proceed, you want to consider another factor. What are the risks of multiple pregnancy with this plan? What are the chances of success? And can I try a lesser treatment? So generally, if you have an open fallopian tube and the sperm function is reasonable, and you have a reasonable ovarian reserve, meaning number of eggs remaining in the ovary, then you would gradually the plan moves from regular intercourse for 3 months or so to stimulation of the ovary and intrauterine insemination to in vitro fertilization. And your specific factors might, or any abnormalities found, may dictate one plan or another. But one question to ask is, can I try a lesser treatment? And sometimes that is absolutely possible. Let me give you a couple of examples. You are 30 and you were diagnosed with polycystic ovary syndrome. You do not ovulate regularly, your fallopian tubes are open, and your sperm function of your partner is fine. It will be a reasonable starting point to induce your ovulation using an oral medication with intercourse or with intrauterine insemination, and try that for 2 to 3 cycles. That has a good chance of succeeding. The next step up is to give you an injection medicine to produce more follicles and do an intrauterine insemination. This is something you may want to avoid because it's associated with more risk for multiple pregnancy, and skip to the step after that, which is in vitro fertilization with single embryo transfer if that is a suitable option. Let me give you another example. You ovulate regularly, you have no problem on physical examination, your fallopian tubes are open, your husband's sperm is mildly abnormal, and his urologist found dilated veins around the testis, and this is called varicocele. Now, there is no evidence that fixing varicocele is going to improve his sperm function to the extent that it will increase your odds of getting pregnant. So if you are young and have good ovarian reserve, you might want to continue to try with intercourse for a few months, and then you decide on the next step based on his sperm function while skipping fixing the varicocele. A third example, if you were diagnosed with endometriosis and you have an endometriosis in the ovary, like a chocolate cyst in the ovary, and your gynecologist recommended that the cyst should be removed before proceeding. There is no evidence that that increases your fertility, and it could be sometimes detrimental because removal of the endometriotic cyst can lead to marked reduction in ovarian reserve because of loss of eggs associated with surgery, and you might want to skip that step and either do a stimulated cycle with intrauterine insemination if the tubes are open, or proceed directly to IVF. So as you see, the amalgamation of information related to age, duration of infertility, the underlying issue, and the chances of success, and the risk for multiple pregnancy is what you should put in mind before deciding on a fertility treatment, so that you're well informed before starting.